And now, I mean, if everybody's okay, we can go on to your next presentation about, let us say, overlapping devices. So please carry on.
Hello, everyone, and welcome to this ANVI Masterclass. Thank you, Dr. Vipul Gupta, for your kind invitation. It is my really honor to be here. I'm going to review this specific topic, which is the overlapping flow diverter, the tips and tricks, and this topic will be related to the second talk that will be in the next session, which is about flow diversion migration, because at the end are both related. If you don't do a good overlapping, you may have migration. So at the end, there are different technical issues to discuss here. So, let me show you my opinion about how to size proximal to distal, distal to proximal. There are different topics to remind and to remember when talking about overlapping flow diverter. Okay, so let's go. The overlapping or telescoping, as you may call it, is an underreported and underestimated. Nobody talks specifically, about this. I reviewed all the trials, and there are some technical concept, but it's not, well estimated. And there are some technical nuances because the potential complications are there, and if you don't do the technique properly, you may have problems because at the end, for sure you will have to telescope the flow diverter for different reasons. Very long segment, maybe this because of fusiform giant aneurysm, or malpositions, or you need a faster occlusion, or the landing zone is short. There are different, possibilities to telescope the flow diverter. Some minor recommendations, just the distance, because it's one of the most issues, is where to place distally, approximately the flow diverter. If you don't have the possibility to measure the neck, or you don't have the 3D or whatever, at least remember, if you see the neck diameter, the minimum is to have the same length proximally and distally. So it's a good orientation. If you are starting or you don't know how to size, if you see the neck here is big enough, at least the minimum is to place distally. If you do that, you are minimizing the possibility to have device migration or problems for needed. So telescoping is an easy technique if you do in a straight segment. So you do in a straight segment is no problem because it's very easy to navigate with the system and then go through. It's important to don't lose the wire of the first stand. If you lose the wire, you may have problems with this technique. And again, it's recommended to do in a straight segment, right? Because otherwise you may push and you may shorten the first device. Another problem is that you do telescoping on the core, on the junction, you may have this type of problems with the opening. Maybe the device don't open well. So remember, if you telescope here, it's better to do the telescoping much more distal in order to have a better opening of the second device. So remember, straight segment and as much distal as possible if you have this angulation. Try to have this problem. So let's see some practical cases. This is a retrobasilar junction aneurysm. We follow up this patient because at the beginning in 2013, the patient was non-symptomatic, then becoming symptomatic. So we decided to treat it the more conservative at the beginning with a Leo stent, as you may see here, and some coils from the contralateral side, the B4. Patient remained stable, but at the end recanalized some years later. So we decided to retreat with the flow diverter. So we decided to retreat with flow diverters, and we are planning the strategy. It's a long segment, so for sure we need to telescope flow diverter. We need to oversize to minimize the perforator's damage. And in this case, which is very straight because the basilar is straight, could be as possible to do from distal to proximal, the conventional way. Minor thing is try to avoid, the telescopic segment here to minimize the risk of perforator damage. So we telescope from the most proximal part, right? So in this case, we navigated first our microcatheter, no problem. We placed in this, it was 2018. I did remember it was a Derivo. Derivo is a 19mm flow diverter. So after placing the first flow diverter, was again very distal here for P1, P2 segment. and we navigate it more proximally. We place the distal location to have a better, stability of the device. Again, the device was oversized. We place the long flow diameter all over the Leo stand, and just below the perforators, we decide to place the second flow diameter. So it was really easy to re-navigate it. Again, was a free segment. So you see here the area telescoping, which was short, but again, it was an easy case to see from the distal to proximal conventional approach. This is the follow-up. You see the stability of the device or of the cloth. For sure, it's a really problematic, vascular. There are very, controversial topics to cover here, but the patient remains stable. Even we realize that the prognosis is poor in this case. Another example to see a fusiform case requiring, flow diameter reconstruction. In this case, again, we select to place very distally the device to avoid, the course in order to minimize the risk of migration from distal to proximal. We did a radial approach, and in this case, we select a Seal Vista Baby, which is a very low profile flow diameter, where you may place the flow diameter through a 17 system. So in this case, telescoping is very easy because right after the deployment, you may re-navigate it very easily, this low profile microcatheter. If you have a bigger microcatheter, you may have problems when re-navigating the system again. So again, in this situation, we place the second one very distal to ensure the stability, and we place the second from distal to proximal in a very long segment. So again, this is an easy technique because it's a low profile flow diameter, more easily to telescope than the conventional ones. And this is the angiographic result of this fusiform case. If you try to telescope in a big aneurysm with a big flow diameter, like the 27 microcatheter compatible, a short pass or pipeline, you may have this type of problem. So this was a really, really problematic case. You see the tight angulation of the M1 here, and you can imagine how complex was to deploy. But at the end, we were able to open fully the device, but the device for short term for sure. And after that, we need to telescope. So this is the situation. You said the stent flow diameter distal in M1, and you have the free segment here. So really, we tried to re-navigate the 27 microcatheter, was not possible. So we waited for there. We felt a lot of tension, and at the end, we were able to navigate it and to telescope, but was not a good technique because this is the ideal segment of telescoping, but we were not able to do this. So if we have this case now, I probably will do a proximal to distal telescoping. And this is an interesting topic, where to do the proximal to distal approach. So this is an example to see a dysplastic bifurcation aneurysm. And in this particular case, we did the sizing using the Siemens size. You see here how much length do you need for this, and for sure we require for using two flow diameter. But imagine if you do the conventional approach and you place the first flow diameter and distal to proximal. If you have the free segment, you may have this type of problems with crossing, and you may have this type of proximal end migration, which is a really potential complication. So in this situation, when you think that you may face in this issue, it's better to place proximally and then distally. So this is the nice ways to do that. And this is the technique that we use. We place in the first flow diameter, and then we navigated the Phenom 27, and we placed the second flow diameter and did the full reconstruction with this proximal to distal maneuvers. So we are finishing here. Overlapping and telescoping seems easy, but potential catastrophic complications are related. You need to know the anatomy. You need to make your plan. Know your material that you have on the shelf and the devices, and for sure, good sizing is the best way to avoid unnecessary. And last talk is just to slide is to show my top 10 technical nuances for telescoping. Avoid telescoping in a free segment. If it's angulated, it's even worse. Don't lose the support of the wire of the first flow diameter. If you have significant angulation, lower the profile, the microcatheter as possible. Remember, proximal to distal is an option where you are having the risk of losing the wire or moving the first flow diameter. If easy re-navigate is a stress segment, then it's okay. Then distal to proximal, the conventional approach is safe. Remember, combined with other stents, it's not necessary to place another flow diverter for different reasons. So you have other possibilities to like placing a laser cut for giving stability or whatever. Regarding the sizing of the second device, remember again, same or larger than the first flow diverter to avoid having problems. Ideal segment of telescoping at least 50% of the device. The minimum should be 1/3, not less. And my recommendation, give an angioplasty after placing both flow diverter for improving their position. And remember, avoid telescoping over perforators like basilar M1 or A1, A2 junction for minimizing the possibility to having problems. So thank you. Thank you very much for your time. And if you have any question, please let me know. Thank you.
Thank you, Mario. Again, a terrific talk. We've covered so many technical aspects, I think. So, Vincent, I mean.
No, thank you very much. Very nice topic. And as we discuss with the flow diverter now being available in a much longer lens, maybe we have less need to telescope, but we still need to telescope. Yesterday we did a workshop with all the Indian teams, and there was a huge, massive aneurysms to be treated, and even with the 5x40, you needed to have two stents to cover it. So it's still something we need to master, despite the longer length of a diverter. And I would say that the proximal to distal for me is the way to go as soon as you can do it, because you do not take the risk of losing the lumen of the first stent. So it's bringing to you a level of safety, reproducibility that you may not have from distal to proximal. The only reason to make distal to proximal is if we're doing from proximal to distal, it will undermine your capability to finding the outlet of the aneurysms. But if it's not, I mean, the level of safety, you just put one flow diverter with a nice anchoring, and again, you underline very well the need for perfectly anchoring the stent when you're doing telescopic, because you have to re-enter, you have to do some massage. So, no, I love the idea you have underlined for us. And maybe it's just a question for you: if you have to select now a technique, proximal to distal and distal to proximal, and the two looks okay, what would be your choice, Mario, now, since you have demonstrated all those experiences?
I think that you point perfectly. So it depends if you are able to catheterize the distal part of the artery. If it's easy or is doable, then proximal to distal is a fantastic option that you mentioned. The problem is you place the proximal flow diverter, and then you are not able to find a way. But at the end, anyway, you have different options for solve it. So if you predict that you are going to need a long telescoping, I would select probably proximal to distal, but it's really complicated. And in terms of the indications, for sure we have long flow diverter, but there are many hospitals that they have some flow diverters on the shelf, but they cannot select, the length because they don't have it at the hospital at the time. So I think that we'll need to be familiar with this technique, even though we have a very long flow diverters in the market.
Great. I think, Mario, you really covered all the technical aspects and the nuances. And as Vincent mentioned yesterday, sir, in the slides training, we made our all the fellows practice the overlapping flow diverters, and your talks has sort of complemented it beautifully. And really, thank you. Record all these videos, be available. You were waiting for a while, and maybe next time when we do, we'd like to have you here in person. Oh, yes. It'll be so great to have you here. And thanks a lot for all the effort. I think let's give him a nice hand. Mario. All right.
Thank you very much. Looking forward to see you guys.
See you soon.
Thank you.
See you soon. Yeah.
See you. Yeah.
Great. Thanks a lot. Okay.